Okay, I'll just let people join as they join, but just in the interest of time, I'm going to get started if that's okay with everybody. So, good morning. My name's Kay Walsh, and I'm the lead nurse for Congenital Heart Disease Network in the northeastern North Cumbria. So, a big part of what I do is this kind of sort of event, bring people together and share some knowledge and understanding around this specialist group of patients. So, hopefully, this morning we'll cover a lot of the I guess that all the things that will matter to you when you come across our patients when they come to you for your support on the programs. Any questions, feel free to ask. That's what the team have sort of given their time this morning, just to make sure you're really comfortable and you get a good level of understanding. So we hope we've pitched it right for you. If not, just keep asking questions and we'll answer as we can. So can we just have quick introductions from the team? Lorna?
Hi, hi, I'm Lorna Carruthers. I'm one of the adult congenital nurse specialists that works at Freeman.
Thanks, Lorna. Vicky?
Hi, I'm Vicky Russell. I'm one of the nurse specialists at the Freeman. My role is surgical coordinator.
Thanks, Vicky. And Dr. Coates?
Hi, I'm Louise. I'm one of the adult congenital cardiologists at the Freeman.
And Dr. Kakala hasn't joined yet, but when he does, I'll let him introduce himself when he comes on to do his talk. So, do you want to do quick introductions as to who you are? Do you want to introduce the team, Jake?
Yeah, I think it'd be worthwhile. Just so
please.
you know who we are. So my name's Jake. I'm the senior manager of the health improvement team, which covers waiting well. Teresa.
Yeah, hiya, I'm Teresa Bramwell and I work with Jake. I'm my opposite him, in fact, and I'm one of the team leads and support the team doing waiting well.
Thank you.
Miriam.
Hello, everyone. My name is Adwa Iba Miriam, and I'm a health improvement practitioner on the Waiting Well team.
Thank you.
Cheers, Miriam. Ruby. I think Ruby and Regina have a bit of an issue with the microphone, so
yeah, no problem.
they're both on the triage team, so they both assess clients as they come into us.
Great, thank you.
And Becca, do you want to go as well? You joined us at the bottom.
Yeah. Oh, hi. Sorry, I had a bit of technical difficulty getting on. I'm Becca. I work for Waste to Wellness. I'm a specialist link worker for the Waiting Well program as well. Thank you.
That's great.
That's everyone. Cheers.
Thank you. Okay, I'll stop sharing that agenda and hand over to Louise.
Right, just give me a minute to share. Let's see.
If you think of any questions along the way and they come to your mind, just pop them in the chat and we can reflect back on them as we go.
Can you see my presentation?
It's just thinking about it. Well, it is on my end. My computer's really slow today.
Otherwise, I'll email it to you if it's. I don't know why it's.
It was thinking about it, but I've just got a white screen as everybody else.
Yeah, so do I. Yeah.
Let me just try again. Okay, let me just try again here. Can you see it now?
Yes.
Yes, we can.
Yeah.
Okay.
Yeah, brilliant. Thank
Great.
you.
So I'm just going to start off just by really giving you a general overview of our population. I'm not really going to touch on surgery too much, rather just sort of, I guess, characterize how we see our population from a medical perspective and some of the issues that they have to deal with. So 1 in 100 babies is born with congenital heart disease, and what congenital heart disease basically is a problem with the structure of the heart, and that might be that there's a hole in the heart or a blood vessel is connected in the wrong way. In some very complex cases, there is only one pumping chamber. These are babies all with very complex congenital heart disease, and you can see they've all had an operation soon after birth. But congenital heart disease is a range. It ranges from very minor defects, some which never require intervention, to very complex defects that need to be operated very early on in childhood. And if we look at congenital problems, i.e. things that babies are born with, we can see in the middle here that congenital heart disease is by far the most common problem a baby can be born with. And this is sort of just a timeline, really, of the last 60 years, 70 years now in the health service and what's been done for congenital heart disease. The first operation was done for congenital heart disease, the Blalock-Taussig shunt, which provided a connection between the right and the left side of the heart to get blood flow to the lungs where the baby was born without it. That was the first thing, really, that enabled babies to survive. But as we got more advanced, we developed cardiopulmonary bypass. We were able to do more complex operations on more difficult conditions. And as we've moved forward into the 80s and the 90s, we've been able to do these types of things. So these are stents with valves in and like an umbrella type device that can be used to close holes in the heart. And these can be delivered through a keyhole operation through the groin, as opposed to having to open the chest and use the bypass machine. Of course, not all operations can be done like this, but it does provide an alternative for some. So what that's really meant is that many of the children who were born back in the 40s, 50s, 60s, who didn't survive with congenital heart disease, are now surviving because we can do so much more to repair it in childhood. And what that has meant over the decades is that we've seen an increase in the adult population. So back in 1980, there were just the first few adults coming through with repaired congenital heart disease. By 2016, we can see that the number of adults with congenital heart disease outnumbered the number of children. And really, obviously, we're in 2025 now, and the population's projected to keep increasing until about 2050 in terms of the number of adults living with congenital heart disease. We think at the moment that there's probably about 4 per thousand in the adult population, but that's going to move forward to be close to the birth prevalence of congenital heart disease, because we expect around 95 to 98% of children born with congenital heart disease now to survive into adulthood. So it's a growing population that wasn't there 50 years ago, basically. The other thing is that as the population grows, we also need to be mindful that some children had operations in childhood and were discharged. Some conditions are never actually apparent. They don't all present at birth. Now we have quite a good antenatal screening program in terms of most women who have pregnancy will have a scan of their baby at 12 and 20 weeks, and the heart is looked at on that scan. So most congenital heart disease, or a large volume of certainly the complex congenital heart disease, is picked up at birth these days, even if the baby doesn't present with symptoms. But there is in the adult population a number of people who are either not known yet to have congenital heart disease because it hasn't caused a problem, or who perhaps were seen in childhood and thought that the operation that they had was a curative procedure and then didn't come for further follow-up. So sometimes these people present to us through emergency departments as opposed to being under our routine follow-up. So this slide's actually back from 2020, but you can get a general idea of the age range of our adult congenital population as it stands. And you can see that it's generally a bit younger than what we might see in a standard adult cardiology practice, people presenting with heart attacks and atrial fibrillation and valve disease, who tend to be in their 50s, 60s, 70s. Our population is rather in their 20s, 30s, 40s. And when we think about congenital heart disease, we just need to think about the fact that it is a lifelong condition. I think as the adult population has grown, we've come to recognise that actually childhood surgery, really, even for mild conditions, was never a curative procedure. And actually people continue to have issues that require support and input as an adult. Whether this is an operation or an intervention or support with the other things that which I'll come on to, which may accompany congenital heart disease. It is a lifelong condition, and our services need to recognise that. Women with congenital heart disease have babies themselves. Babies may have congenital heart disease. So this needs to be all incorporated into the sort of understanding of the condition. When we think about, I mentioned already that there is different levels of congenital heart disease, and we do have a way of classifying that. So you don't really need to look at the detail on this slide, but other than to say that there are two things. There's the anatomy, that's the structure of the heart. So what's the problem with the structure of the heart? Is it a small hole in the heart, or is it a more complex defect? And we divide it basically into simple, moderate, and complex. But the anatomy is not the whole story, because we know, like if we look at, for example, people with amputations, there are some people winning Olympic medals with amputations, and there are some people unable to get out of the house with amputations. So a structural abnormality does not necessarily correspond to the functional effect of it. And so we also classify by functional effect or by physiology, and that's classified A, B, C, D. And this is just a sort of a guideline classification that we use. But A would be no functional problems. B, there might be some rhythm problems or some breathlessness when walking. C, that's like more, and then D is very severe, so the patient's unable to do anything. So when we think about the severity of adult congenital heart disease, we think about it in this way. And as I mentioned, there are some conditions which are diagnosed for the first time in adult life. So whilst the vast majority of our patients live with congenital heart disease from childhood and have often have had multiple interventions in childhood, or experience of healthcare, there are some who come to it anew, and that can be a big shock to people to know that they have something quite significant, because it often is significant when it presents in adulthood, because by that time it's built up enough symptoms to cause a problem. And one of the times it might present is during pregnancy, for example, when the heart is under more stress, or other times when the heart is stressed. Now, this is what I just really want to come on to, is that actually congenital heart disease is not just a problem of the heart. And we know that lots of our patients have other things that they live with. You might have heard of the term multiple long-term conditions. Well, I think this, like congenital heart disease, really embodies that. There's quite a significant minority of our patients who have genetic defects like Down syndrome and other rarer conditions that are associated with congenital heart disease. There can be the effects of childhood surgery. So the X-ray there is of somebody who's got what we call kyphoscoliosis, or curvature in the spine. And that could be a common finding after an operation done through the chest. So the heart may be treated, but the patient may be left with a skeletal problem. Liver disease can happen in people who've got residual problems on the right side of the heart, where the liver gets congested. And there can be infective problems here at the bottom right. You can see an abscess, an infection in the brain, which has come from the heart. And something that is highly prevalent and really that we're increasingly seeing is mental health and conditions associated with living with congenital heart disease. And some of this is perhaps changing because the treatment of children with congenital heart disease is changing. Back in the 50s and 60s, children didn't necessarily have their parents in hospital with them. Our processes for managing things like pain and anesthesia is changing. But nevertheless, we see that about a third of adults with congenital heart disease have mood disorders. That's anxiety or depression, with anxiety being the most prevalent of those two. And there's also about 20% who have post-traumatic stress disorder. There are high levels of problems, for example, with having bloods taken, concerns about anesthesia, and there's a lot of worry about things like surgery. more recently as well, it's because there's been some work looking at what's called frailty, and you may be aware of the idea of frailty in older people. It's a combination of cognitive dysfunction and also physical dysfunction. And when we look at we see in adult congenital heart disease that this happens at a much earlier age than in the normal population. And so often people in their 40s and 50s can be what we would recognize as frail. And when we look at what are the predictors of those things, the patient being frail, it is these things I've talked about. So the complexity of their congenital heart disease, their functional status, but also their comorbidities. Importantly, this idea about deprivation and income and social status is also associated with frailty. And although I haven't put it on any of the slides, there is actually a bias in congenital heart disease towards people being in the more deprived groups. And there are lifelong reasons for this. Some of it is to do with perhaps things not being picked up antenatally because there is a reduced attendance at antenatal scanning, late presentations, and so on. So we do actually see that there is a slight bias towards people being in the quintile 1, or if you know what the IMD, the deprivation 1 and 2 groups are, or the core 20 group. And the effects of all this on the individual can be to actually engage with their healthcare in different ways. So this is just some work that's been done looking at how adults with congenital heart disease engage with care. And there are, for some people, having congenital heart disease just overtakes everything in their life, and everything is about their congenital heart disease. This group have quite high levels of depression and anxiety and often interact with healthcare quite frequently. There are people who just want to push it to one side and actually just, say, that's not happening to me, and just reject it and are sort of in denial about it. This can cause problems because actually they may DNA clinic quite a lot. They can then present late with problems that possibly could have been avoided at an earlier stage. But there's also a group who accept it as part of their life and just get on and interact normally with healthcare, come when things are needed. And then we have the group who it really enriches their life, and these are the ones who sort of will tend to be very active with patient organisations, maybe supporting others with congenital heart disease. One of the issues in our clinics, and you can see on the map here, this is the sort of region we cover in the northeast, is that our patients are coming from a long distance, some of them locally. And I've already mentioned that people with adults with congenital heart disease can interact with healthcare in different ways for a variety of reasons on that background of comorbidity and mental health, psychological issues that may be long-standing. And we do see that quite high levels of non-attendance in adult congenital heart disease. And again, these are often biased towards those more deprived groups. In London, there's been evidence showing that it's related to ethnic minorities. We haven't seen that so much up here. But often people who think that they have mild disease are younger, because actually you're often able to function much better when you're younger until the point that you can't, will often not attend or delay clinic appointments, which can create problems going forward. And we see this because this is actually data from America, but we've seen exactly the same in our region. Emergency level A&E attendance is increasing amongst this group. So patients who don't go to clinic, we think may attend A&E intermittently instead. Now, just on top of this, we also have the fact that there's everything else that causes cardiovascular disease, and that affects these patients as well. Smoking, alcohol, diabetes, obesity, and so on, which are standard risk factors for coronary artery disease, are actually quite prevalent in this population, and interestingly quite prevalent in those who have the milder conditions. So that creates an extra burden on top of a heart that already has structural problems. And one other thing I just want to briefly mention is something called endocarditis, which is infection in the heart. Infection in the heart is common in people who have had, well, it's not common, but more common in people who have had operations on their heart, who maybe have metal heart valves. And it can be absolutely, in a patient who is otherwise well, it can be, of significant effect, clinical effect. And we know that in adult congenital patients who get admitted to hospital with this condition, 1 in 15 don't survive. And I'm sure Vicky will mention when she talks about dental preparation for surgery, keeping the teeth in good condition is one of the things that we can do to try and reduce infection. But having that just awareness that infection, wherever it occurs in the body, can be of more importance for these patients, because if it gets into the heart and causes infection in the heart or endocarditis, it can lead to serious problems. So in recognition of this growing patient group, and the fact, as you can see in our region, but in regions around the country, these patients are spread everywhere and have lots of difficulties with their care, because their care is delivered typically by a specialist centre. But many of them live a long way from a specialist centre. Many of them have other competing interests, being young adults. They might have children, they might have jobs. There's relatively high levels of deprivation, and there's other needs within the group. And so back in 2016, there were some national standards made to try and standardise how we deliver care for these patients. And there was the development of the networks, of which Kay is the lead nurse for our network in the Northeast. And our network in the Northeast covers the area right over to North Cumbria, up to Berwick, and down to North Allerton. So a large area. And these are the standards that I'm talking about. And these are really just about what we should be able to offer these patients, both in terms of what we do in the specialist centre, but what we also do in district general hospitals. And also considering the patient, as I've already described, in a more holistic manner. So not just about their heart, but really about those other elements, the mental health, support through psychology. And I think we're a long way off achieving most of these standards, but at least there is more awareness of these are the things that are important. And I think this is where the Waiting Well programme really fits well for these patients. So yes, that's just to show where our hospitals are in our region. Now I know we're really just talking about the Newcastle area today, but we do have patients from a wide range. So to summarise from my perspective, the adult congenital population is a growing group who weren't there 50 years ago. The group itself is getting older. There's more complex patients coming through. They're generally younger than other cardiac patients. The severity of their congenital heart disease and the severity of their functional status affects their risk. There's high burden of other problems apart from their heart, and importantly, including mental health. There's a high burden of conventional cardiac risk factors, so like obesity, smoking, diabetes. There's varying patterns of engagement with healthcare, and the networks have been very helpful in aiming to promote care equity amongst patients and support education like this. So that's all I've got to say, really. I hope that sort of gives you a bit of an idea about the population and some of the medical issues. And I'm sure Lorna and Vicky will follow on to explain how this sort of fits into the surgical pathways.
That was great, Louise. Thank you. Really great foundation. Jake, do you want to come in there?
Yeah, just slightly, like, just for my team especially, a lot of the stuff that was mentioned there regarding smoking, weight management, obesity, alcohol, that's exactly what we deliver on the day to day. So yeah, just bear it in mind when we're going through the next bit.
Thank you. Lorna, I'm going to hand straight over to you. I'll just collect any questions in the chat just so we can keep going.
No worries. I'm having, let me just check if you can see mine. I don't think it's going to let me share. Sorry, I'll be 2 seconds.
It's all right.
Complete technophobe, as you know. Share. Can you see my slides?
Nothing happening yet.
Right. I've tried. Still nothing?
Is it giving you a share option?
Yeah.
I was going to say I gave you all. Oh, it's doing something. No. So it is sharing, but it's sharing you the wrong screen.
Which screen's it sharing?
Like all of our faces, which is quite disturbing.
I'm sorry
Need
about
to
that.
leave them
Hang on, I'll
back
stop
on it.
sharing all your faces.
Thanks.
I do apologise, everyone. I'm not very good. I'm not very technically minded. Let me try this. I'm so sorry.
You're fine.
Share. Anything yet?
Just thinking about it.
It's loading my presentation.
Yeah, it's up on mine.
Coming.
Right. If I do that, does it work?
Yeah, it's on.
Yeah. Is it on in a weird way for you?
No, it's on absolutely fine. It's your
No, I'm
normal.
Yeah, no.
Now it's trying to send me an email. Excellent. Oh, this isn't
Right, I've got control of them if you need me to move them forward.
right.
So
This
just let me
isn't.
know what you need.
It's not my presentation. Oh, I'm so sorry,
Just email it to us.
Hannah. Windows 2. I don't know why I can't do this.
Just email it.
Right, I'm just going to talk. I'm just going to do it. Okay. So you can still see my slides. So mine's just a little bit of a follow-on from Louise. This talk's normally given over an hour and I've condensed it, but for some reason it's not going to let me do my slides today. So as Louise said, is it doing it for you guys? Because they're not moving for me.
Well, they're moving on your screen. Can you see the aims of today's slide?
It's just blank. It's
Oh,
the slides are up, but it's just there's no
It's
writing on it
just
for
blank.
me.
Yeah, that's what it's
okay.
doing. Right, let me stop sharing. Right, I'm really sorry, people. Open that. I'm having another go, another way. I'm a better nurse than I am presenter, so don't panic. So slideshow. It's on my screen. I just can't give it to you for some reason.
It's on your screen. Go to share now, and then it'll give you, when you click on share,
Yeah, it
it'll
says
give you which screens you want to choose.
it doesn't. It says, do I want to go on NHS OneDrive or add my presentation to an email? Yeah, it's just been really awkward.
Why don't you just
I let
email
Vicky?
it?
Yeah, you email it to me and I'll let Vicky go now.
Right, I'm so sorry. Go,
Vicky, are
Vicky,
you
ignore
happy to go
me.
now? Yeah, right, Vicky, you go and
Yeah.
I'll get loaders up on my end.
Sorry.
Yeah.
Thank
No,
you.
yeah, I'll go now. I'll not have any technical issues because I was just going to have a bit of a chat and discussion, if that's okay. So my name's Vicky Russell. I'm a part of the nurse specialist team at the Freeman. Prior to this, I was a sister on the paediatric ward at the Freeman. And then I've been part of the specialist nurse team for about 5 years. And then most recently, the role of surgical coordinator. The role was implemented to sort of streamline the surgical pathway for our patients, and it's for all of congenital heart disease. So it's paediatric and adult. But obviously we're just going to be talking about the adult patients today. So as Louise had said, you know, patients are seen in our outpatient clinic at various stages throughout the journey. When it's decided that the next steps for a patient is probably going to be surgery or some kind of intervention, the patient is brought to our departmental MDT, which happens every Wednesday. This is where all the cardiologists, surgeons, anaesthetists, intensivists get together to discuss a patient and see what the next part of their journey, part of care is required. And that's when they would be, if accepted for surgery, they'll be put onto our surgical waiting list. From then on, they get an appointment to come and meet with our surgeon in the consent clinic. Part of the specialist nurse team is at that clinic appointment as well to answer any questions. We do ask if the patients bring somebody with them to that appointment, whether that's a family member or a friend, just so they've got somebody else there to support them. And also there's a lot of information usually to take in, so just so they've got sort of another pair of ears there as well, and obviously ask any questions that the patient may not have thought of at the time. At that appointment as well, if not previously, some patients before surgery would need CT scans, ultrasounds arranged just to look at the anatomy and see exactly what the surgical options are going to be. So they've often got to come back for several appointments. We do try and get those appointments on the same day if possible. It's not always possible. Obviously, some patients travel quite a distance, so we'll try and arrange those appointments the same day. But as Louise mentioned about being dentally fit for surgery, with the risk of endocarditis, we need to make sure that patients are regularly seen by a community dental and have yearly checkups. Obviously, at the moment, there's a lot of dental practices on and taking NHS patients now, so this is a huge problem at the moment. We do have an oral health department within the hospital, so we can refer patients there if they're unable to be seen in the community, but that's happening more and more, so just something to be aware of as well. And we also have to get patients to come to a pre-assessment appointment before surgery. This is when they meet with the anaesthetist, make sure that they're fit for the anaesthetic. They'll have bloods, chest x-ray, ECG, things like that performed. The waiting list at the moment, we've got 3 surgeons. Our newest surgeon started the beginning of this month. So they all have a waiting list. It's about 6 months at the moment, but a lot of what our work is... Oh, has the sound stopped? Did that say? Can you hear?
No, I can. Yeah,
I
I can
still hear
still
you.
hear.
Sorry, I just
Yeah.
saw a
Can hear
message
you.
pop up there. All right, sorry. Where was that up to? Oh, a lot of the work that we do here is emergency. So we do have an elective waiting list, which is what I've mentioned, where patients are put on the list, and it's approximately 6 months wait at the moment. But then we do have sort of emergency surgeries coming in, newborn babies, so our surgeons operate on all congenital heart disease, so children and adults. So along with that, there's also a high number of cancellations, which I think is really hard for patients and families to cope with. Sort of, you know, being mentally prepared, sorting family members out, work, all things like that. And then often surgery's cancelled on the morning of surgery if there's an emergency, if there's a problem with an intensive care bed. So that's a huge problem, and it is really frustrating for obviously ourselves, but also the families, and the patients and their families. We always mention that in clinic about the risk of cancellations, and obviously everybody understands why, but when it happens, it's obviously very distressful for the families. We've also at the sort of the consent appointment or previous, you know, the cardiology appointments beforehand, if we need to involve our learning disability team, if there needs to be any adjustments made for when they come in for surgery. So the adult wards do have cubicles. So if we have a patient with a learning disability who may need a family member to stay with them, we can request cubicles. Obviously, it just depends on the day whether those cubicles are available. But we do work with the wards to try and get those, and also younger patients, so sort of 18-year-olds who would be going through the adult pathway. They're used to being seen through paediatrics. Often it's difficult for them, so we do try and get a family member to stay with them when they come in for surgery. I'm also going to involve the mental capacity team if there's any issues with regards to that, just for support. We do have best interest meetings to make sure we're obviously working in the best interests of the patient. I think that's about it.
I've just got a quick question, if that's all right, Victoria.
Yeah.
So you mentioned like surgeries being cancelled. Is there any other reasons why the surgery might get cancelled, e.g. below a certain BMI, or is there any like lifestyle related reasons why it might get cancelled, or is it just...
Good question. So if a patient comes who threw out the MDT and to the consent clinic, if there's an issue with maybe his weight and we need to lose weight, that's addressed at that appointment. So they would keep an eye on them in the cardiology clinic and wouldn't be listed for surgery until they're at a satisfactory BMI. There's also been a lot of mention, obviously, at the moment with weight loss medication and things. So some patients are seeking those to help. Yeah.
Are they using the weight loss medication now, or are they not allowed to use it, or is there any?
Yes, yeah. There's no... Louise, you might want to jump in here.
Yeah, no, I was just going to say, I think we've been really struggling over the last couple of years to actually get patients into weight loss programs. But I think increasingly the ones who can afford it are purchasing it now, and we're seeing really good results. And there isn't any real reason that these patients can't take it in any, the same side effects as anyone else, really. I think the difficulty is obviously where patients can't afford it. And they're not meeting the NICE criteria, which is basically that you have to have diabetes plus other criteria.
Yeah.
So there is a group who aren't accessing it who really would benefit from it. And we've got a few who basically can't be operated on, even though they need an operation, because we're unable to get their weight down.
Right. No, it's just interesting because that's where we've been seeing more and more people coming through who are using the Mounjaro or Ozempic to reduce the weight. So it's just for the team's point of view, if they get people who are, if there's any issues with it, but if there's not, that's fine as well.
Jake, can I ask you a question? Of those people that you've seen coming through, taking the weight loss medication, are they wanting to do physical activity as well, or they're wanting to get into exercise, or is it kind of, if you've seen that people aren't that bothered and they just want to lose the weight?
Usually if they're active before, or they have been active, and the weight's a reason why, for example, arthritic knees, the weight's a reason why they feel like they've been unable to exercise, then they're the ones that tend to be taking it up. But if they've never exercised, then they don't start. We haven't seen a trend in them starting to exercise. They're happy just taking the Mounjaro if they're losing weight. That being said, exercise is the restrictions around what exercise people can do, what we can recommend. We've got a lot of exercise classes which we run at Healthwork, so
I guess it's just to be mindful that some of the patients are waiting for surgery, and some of the patients have significant maybe blockages or leaks in their heart, and so I think it would have to be on an individual patient basis, that there would just need to be a little bit of a discussion. Generally, we want to keep people mobile before surgery, and we want to keep them active and doing things, but it's just what the individual surgery is for, if you see what I mean. just to probably just have a discussion.
Yeah, no, that's fine.
Lorna?
I'm going to have another go. It said I wasn't connected to the network. Can you see those slides?
Yeah.
Yeah.
Yeah, I'm going to try this. Right, can you see slides again now?
I can see them in not in presenter mode, but they're there.
Yeah. So can you see them in presenter mode now?
Yep.
Yeah.
Yeah, right. Whew. Fourth time lucky. Okay, I'm just going to do a brief overview of the ACHD adult patient journey. So what is the patient journey? Well, it's a bit like Dr. Coates has said, it's a lifelong process that involves transitioning from paediatrics to adult services, and it's managing the complex heart conditions that our patients have and adapting to various life stages that they come across. So this is just a slide. So again, as has already been mentioned, it's lifelong. So it's fetal diagnosis, going into infancy and early childhood, going through your teenage years, the honeymoon period, if you like, then you're going into adulthood, and then you're going into your elderly years, which is happening more now due to advancements in technology. So the lifespan and the ACHD population has grown because we've shown improved survival through childhood. We have better and earlier diagnosis in people, and congenital patients who reach 18 will now be expected to live into their 70s. And this is partly due to advancements in medical technology. So this is a thing I always laugh when I give a talk, adults versus pediatrics. So if you look on the left, that's Florida, that's Disney World, that's pediatrics. It's all singing, it's all dancing, you've got everything. If you need anything, you've got lots of resources. Then you come over into adult services, and we're a bit like Blackpool Pleasure Beach. We've got certain things, but we don't have the money and the resources in pediatrics, which is a big problem. So how do we manage our complex CHD patients? Well, not all our patients are ever going to be fully fixed or cured of the conditions they have. So what we need to do is try and manage their care in the best way we can. So that may be medical management if they're not suitable for surgery or a procedure, and we can manage them with medication. We may look at intervention. So that would be things like if we've got a narrowing, we can unblock the narrowing with balloons or stents. And in some rare cases, our patients are palliated because we're not in a position to offer them surgery. The medical management isn't working anymore. So we palliate people for symptom management and control. That doesn't mean we're going to stop seeing them. We're just going to involve other teams to ensure that they're going to receive the best care that they possibly can. And it's just to highlight that when we say they're having palliative care, it doesn't always mean that is the end. We involve palliative care. It's another team that we work with because it can help with symptom management. It can improve the patient's quality of life. It offers support not only for the patient, but also their family. And in some cases, when palliative care are involved, it can prolong life because the symptom control and management is so good, and it allows for continuity of care in their home as well. So this slide, this is basically what I do on a weekend, not. It's just to talk a bit about lifestyle adjustments and what our patients have to think about that maybe you or I wouldn't think about on a day-to-day basis. So I've just put a long list here. So lifestyle adjustments, as we've mentioned, diet. Ideally, a lot of our patients, if they want to have surgery, what we're looking at the moment is a BMI, and we like the BMI to be 30 or below. And this is because when they're having surgery, especially people who've got bigger chests or females who have breasts, it's much harder to get the chest closed and stay closed. So that's why we want them to have a lower BMI. We also tend to find people who have greater BMIs are more likely to get chest infections because they're the people who are less likely to get out of bed following surgery. And as we've mentioned, we are having issues around diet and BMI, and we are trying desperately to work with GP practices to look at weight loss injections, weight loss medication, or indeed exercise programs. lifestyle adjustments, physical activity. All our patients, depending on what type of cardiac lesion they've got, their physical activity is very much dependent on that. So some people may only be able to walk, and then you've got people who may be able to do half marathons. It just varies depending on them. We're very big on dental and making sure your teeth are okay, because if there's an issue with teeth, it can cause bacteria to go into the bloodstream, which can go to the heart. The other problem we do have with dental, though, a lot of people don't have the money to pay to have dental work done. Our patients need to look very carefully at their alcohol intake and smoking or vaping, because these are all things that can affect their health and the heart. So we talk about that. Pregnancy, some patients can get pregnant, other patients we advise not to get pregnant. We offer in hospital a service. We have 2 clinics a month where the obstetric team come across from the RVI, and they support patients with heart disease who are pregnant, and that can be before they're pregnant, having pre-pregnancy counselling, and when they're pregnant. And we can also plan for delivery. Say if they were high risk, we would want to bring them to one of our centres a bit closer to home. So we monitor the patients throughout. The other things that we would probably take for granted, houses. A lot of our patients can't get a mortgage because they can't get life insurance because of the congenital conditions. So this is a big issue. Holidays. We all want to go on holiday. A lot of our patients struggle with this because they have to have holiday insurance, and the insurance is often costs way more than the actual holiday. Employment. Can they work? Are they able to work? Do we need to look at getting them adjustments in the workplace? Not everyone can do a 12-hour shift. Not everyone can manage on 1 half-hour break throughout the day. We might need extra breaks. So we work with the patients and their employers by writing letters, speaking to the employers. We have in the past gone into places of work just to explain, because the thing we find with a lot of our patients, they look absolutely fine on the outside, which is why they run into lots of barriers, but it's inside that's the issue, because not all our organs function as well. Relationships. People struggle with relationships. Can they be with somebody? We've got scars, we've got lumps and bumps that other people don't have. This is a big issue for a lot of our patients with body image. Insurance, things again like life insurance, car insurance. These are big things to our patients because they don't just come as easily. Medication. And because congenital heart disease, it is recognised, but not by the government. So some of our patients can be on 12 to 13 medications. They don't get their medication free. So we have to look at that as well, because they have to pay for the meds. So that's why we have had issues in the past with compliance, and it's been due to cost. We talk about tattoos and piercings. We give advice. So we advise people, if you're going to have a tattoo and a piercing, to just go somewhere clean. So you're not going to introduce any infections into the blood, again, like you do with the teeth. At the end of the day, we can just advise. You see patients coming into clinic who've got sleeves, tattoos everywhere. It's the patient's choice, not ours. Psychological support. So we've spoken about this. This is huge, and we don't currently have enough resources within the hospital to support our patients who need psychology. And I think the psychological input they need is lifelong. They've been born with this. It's not going anywhere. It's staying with them for life. So they need that. Transitional periods are when they need it most. You're going from your Disneyland, Florida, if you like, clinic in peds, and then you come into Blackpool Pleasure Beach. It's very different. Still, in some cases with our hospital, the same staff, but it's a massive step in their journey. And the other thing is surgery and intervention. A lot of our patients have post-traumatic stress because things have happened when they're a child. They weren't with the mum, the mask coming onto the face, having an anaesthetic. So it's things like that we need to consider. And the network have been supporting us with psychology, but unfortunately the funding's withdrawn. So at the moment, the only people that we can offer psychological help to are people who are waiting to undergo heart or lung transplantation, which obviously isn't ideal. And I've mentioned the PTSD clinic appointments. I've basically mentioned this. Too many patients, not enough money, not enough resources. We've got the psychologists there. We just don't have the money to fund the service. Education and empowerment. I really like this. So if you give your congenital patients access to information and knowledge, it will allow them to lead richer and more independent lives. So I think the service that you guys provide is amazing, and being able to share it with us again is amazing, because I think it really is going to benefit the ACHD population. And the education and empowerment and all the resources we have allows our patients to have more autonomy. We can do teaching sessions in clinic with them. The patients have a voice. They can ask questions. We go over and over things, but that's when it sinks in. And they always leave our clinic. We have cards with our contact details. So we're available as a nursing team Monday to Friday between the hours of 8 and 5 to be contacted. And we can be emailed at any time. And this is just about the importance of adhering to care and communicating with your patients. So this means we can increase medication adherence, we can support them with the lifestyle, we can make them autonomous, make them more responsible for themselves. This will promote their well-being. Communication is key with any patient in any speciality. Patient education and offering professional support. So I think the more resources we have, the more support we can provide for our patients. That is me. I'm sorry if I've ran over.
That's absolutely fine. Thanks, Lorna.
No.
Any comments for Lorna?
Thank you, Lorna. It was just
No
a
worries.
question in general.
Yeah.
Is the plan from your end to get them to us as soon as they are ready or going to be put onto the waiting list, or what from your end, just so we know basically?
Jake, I've already got a list.
Have you? All
We're
right,
ready.
then.
As soon as we knew we had this, Dr. Coates is obviously one of our first consultants who has known about it, and I was involved with it. So we've already started looking at what the support you offer and what patients we have. So I've got 3 on my hit list for you so
Right, that's
far
fine.
that we're hoping to refer. Yeah.
Yep, no, that's absolutely fine. Yep, all right,
Yeah.
that's answered my question then.
No worries. I do apologise because I have to go because I'm off today and I've got another appointment. So I'm not being rude, but thank you very much for your time. Thanks.
No,
Thanks, Lorna.
thank
See you
you.
later.
Cheers.
And we have Dr. Kakala. Are you there? Oh, I can see him now. Oh, yes, he is. Hi. Can I
Hi.
just let you introduce yourself because we did ours earlier? Are you happy to just introduce yourself and your talk? Is that okay? Or do you want me to do it?
Yes. Hi. Sorry for joining late. I'm Dr. Carl. I'm one of Jan Carl. I'm one of the congenital consultants in Newcastle, and my area of interest mostly lies within arrhythmia. But I've been asked to give a couple of minutes talk on congenital heart disease, a little bit about heart failure, and a little bit about arrhythmia. Is that correct?
Perfect.
Yes.
Yeah.
Good. And just so I can understand the audience, Kay, you said it's a variety of community-based.
I'll let Jake tell you because he's
Please.
expert
Thank
in
you.
his.
Yeah, no problem. Nice to meet you. Yeah, so we offer almost a 12-week intervention within the community where we'll work one-to-one with hopefully people on your waiting list for 12 weeks. We've got an hour a week where we can work with them. We'll work on things like diet, smoking, alcohol, exercise, a whole range of lifestyle points, and hopefully at the end it's either reach the goals in reducing weight or helping them to reduce their alcohol intake and quit smoking. We also have a stop smoking team at Healthworks, so they're on hand to ask any questions that we might have as well. So yeah,
That's excellent. Thanks. Okay. Well, some of this is a little bit medical, some of it isn't. So just ask questions as you go. I'll try and share this.
There may be a bit of duplication just because of the nature of the talks, so just bear with us if there's a bit of duplication across the slides.
I imagine there probably will be, but yeah, apologies for that. It's not very long, so this is probably duplication here. Congenital heart disease it's a significant population when you add up all the numbers. So it comes up to just under 1%, but much less than that is under follow-up. And so I'm just going to try and see people's faces as I'm going to talk. The proportion of patients in different groups varies, but majority of patients with congenital heart disease don't have very severe disease, although those are the ones we seem to see all the time because they're the ones that seem to get most of the interventions. So I think the point of this slide is to say that there's a lot of interventions across the different groups. The proportions within each group will be variable, and this population is growing as more and more patients survive these interventions into adulthood. Again, this is probably duplication from previous slides taken from very nice guidelines, but essentially the course of these patients is not a one-stop shop type thing where you get an aortic valve and then you never see them again. This is a lifelong journey for these patients. They'll get interventions, many of them from childhood all the way to geriatric care. And so every one of these time points where they have some indication to do something is an opportunity to try and adjust their life course, because the consequences over decades is significant. So it's a huge, huge impact, much more than a one-stop shop type thing. The figure on the right doesn't fully apply to here, but I think it's a nice figure. It's just to say that the more complex the anatomy and the more complex the patient, the higher the proportion of complications that they get. So in some ways, they're perhaps more deserving of these interventions to try and optimize their pre-surgical kind of state. And this is Dr. Coates' material, which is very nice, but essentially it says these concepts don't just apply as a general sense, but also locally. As you can see, that a large portion of reasons people come into hospital is because they have surgery or catheter or pacing. So this takes up a large proportion of their time and their healthcare usage. In addition, with slight relevance to this talk, arrhythmia and heart failure account for a large proportion of the reasons they come to hospital in an unpredictable manner. So the material covered here is relevant and on both sides of the spectrum. This is perhaps already covered as well. Heart failure is very, very common. Almost half of the patients with congenital heart disease will have some form of heart failure or heart failure admission over their lifetime, and that proportion increases as they get older. And similarly, arrhythmia, which has a huge overlap between the two, is very, very common. So these are two of the probably commonest reasons these patients present to healthcare. This is just a busy slide, but essentially shows that arrhythmia, which is electrophysiological abnormalities, and heart failure, which is often related to these features here, are all linked, and the two interplay with each other. Heart failure and arrhythmia in isolation are triggered by lots of different things that can happen to their physiology and their anatomy. And this is just a block listing of various types of things that can trigger these problems. And the not unique, but the more prevalent nature of this population is that a lot of these things are reversible, and often reversible through specific interventions, i.e. surgery, catheter interventions, etc. So it's distinct to the acquired heart disease population where those things are progressive and mostly treated through medical therapy. This patient cohort will often have a structural complication or a arrhythmia complication that we can address in some way. And this is kind of what I've just said. The definition of heart failure, not getting enough blood to the different parts of the body, and the management is not necessarily the same. It depends on their individual anatomy and individual repairs. And often there's a structural complication or an arrhythmia complication that we can address to try and bring them back into the right track. This is more of the same, essentially saying that there's different abnormalities that we can try and correct to improve these patients' quality of life and prognosis. Nonetheless, those with heart failure tend to be in a higher risk group. They're much higher risk of dying. It's the most common cause of mortality. And these patients use a lot of resources, both in terms of outpatient and inpatient needs. However, with these types of treatments, we can try and bring them back into a better prognosis. And this is just a figure to say that those get heart failure do worse in every category. So this is a worthy group of investment, time, and intervention. Nonetheless, this is a very popular figure. No matter what you do over the course of decades or years, depending on the patient, you don't generally get a higher disease burden. But there's this long period of time between these interventions where we can try and maintain quality of life. One slide it's an under-researched area, no doubt, looking at quality of life specifically in these patients. But in tetralogy of Fallot, which is one of the most common conditions, heart failure and lifestyle factors seem to have a very large impact on patients' perceived and actual quality of life. And these are different risk factors that look into that. And I've just highlighted some of them, of which many of them are related to the kind of interventions that can be offered in the community, i.e. there's a couple of studies in congenital looking at specific physical activity of 3 hours a week or more, and that seems to be a time marker. Smokers have a poor quality of life. If you have no heart failure, which is this, you have much better quality of life and symptoms, of course. 2 slides on arrhythmia. Abnormalities on heart rhythm is really, really common. Very busy slide with lots of different conditions, and you can see there's lots of different pluses and lots of different boxes. They represent different types of arrhythmias in different patients. So it's not one box fits all. It depends on the different anatomies, and we follow up patients very closely for these sorts of abnormalities. Some of them can be fast rhythms of various natures, some related to the way they're born, some related to the repairs they've had, and some are less predictable. And they can also have slow rhythms, and those are patients we refer for pacing, either with me in the lab or surgically. And this proportion is variable depending on the different regions that study this problem, but arrhythmia in a lot of cohorts and regions, including in England and in the UK, is one of the most common causes of admission to hospital. So this is a very common problem that often requires some sort of intervention, i.e. pacing or ablation or whatever. And this is purely to say that the management of arrhythmia is unique to each patient. There's no common pathway. Most of them are discussed as a group, but quite often they'll come away with either medications of some nature, ablation, or pacing, of which there's various pictures here described. So these patients often end up needing some sort of procedure. This is a very helpful publication for me, at least, looking at the different types of interventions we can offer for arrhythmia. The concepts are the same as in the general cardiology population, but the applications may be unique. The way we do it may be unique. And these things, there's a long list of things here that I've mentioned, different types of ablation, different types of pacing and medications. They kind of work in parallel with the heart failure management as well. So you can imagine over a course of a congenital patient's lifetime, they may tick lots of these boxes as they progress. So this is a high burden kind of cohort. I'm not an expert in this specific subfield, but I guess it's relevant to what you guys are doing is the safety of these sorts of things. And again, it's not well studied. Heart failure patients, arrhythmia patients awaiting interventions. From what I can gather and from what my experience is, it's overwhelmingly safe, actually, in the vast majority of congenital patients. There's very little data to support lack of safety. However, there are some individual high-risk subgroups, which I've written a list of stuff that we have to consider, that may have a higher risk of decompensation or lower exercise tolerance, but vast majority, they can do aerobic exercise up to 70%. And indeed, that is significantly beneficial. And these very, very high risk, small subgroups, of course, you need to have tailored programs, in which case we might get CPETs, et cetera, but all of that should be documented in the notes as a exercise prescription almost. And of course, there is some data, increasing data, I'd say, of the consequences of extractive restriction, which was done historically in this cohort, raised BMI, smoking, et cetera, and the impact on their quality of life, surgical complication, and long-term outlook is significant. And this is just a very recent publication looking at a general feel for, moderate and high complexity congenital patients, which probably account for a significant proportion of patients having interventions. And you can see that, the degree of limitation that this cohort has is significant. And the higher the complexity, the more likely they're going to have these sorts of physical limitations. This is a nice piece of work because it looks at motivation as well. And you can see that motivation is very, very high amongst this cohort. And indeed, complexity does not really reflect the ability of the patient having motivation or not. They just have various limitations. So I think access to rehabilitation for these patients would be valuable. And this is just a very, very quick slide to say that there is a lot of data published. I don't know the basis of this is, particularly looking at different types of exercise for different congenital patients. And this is essentially alluding to what I mentioned in terms of the very high risk patients are not excluded from exercise. It just has to be adapted in some way. But again, this performs, these patients in this category are a very, very small group. Most of the patients in the congenital will be in the first three categories. I think we've alluded to this again, and second to last slide, just to say there's a couple of studies looking at specifically cardiac rehabilitation, heart failure, arrhythmia patients having rehab, and overwhelmingly the data suggests safety. I don't think there's been any adverse events particularly, and benefit in terms of various metrics in terms of their ability to improve their cardiovascular fitness. So I think it's a beneficial thing to do. All of this has been covered mostly over the last 10 minutes or so. But essentially, triggers are very common for heart failure and arrhythmia based on structural issues or arrhythmia issues, and this is commonly a reason for us referring for interventions. Interventions are very common generally across this cohort, and there's usually a very low risk of intervention overall with a high reward in this large group of patients, many which are young. And I think most are safe to have rehabilitation, of course, and will derive benefit. There's lots of different information areas. I think at the point of referral, there'll be, if you're concerned about specific high-risk features, and of course, we'll prescribe essentially what we think the patients can or cannot do, but the majority can do everything, and that information is in the clinical letters, guidelines, etc. And as Lorna just mentioned, there's a specialist nurse available during the week for specific queries, and ACHD consultants are available all the time. I think that's everything I have to say.
Great, thank you.
Thank you.
Okay, so while we've still got, well, I know we haven't got Lorna, have you got any questions, any thoughts, anything? Obviously, we're not going anywhere, so we're always available at the end of an email. Any questions you can think of, anything that comes up through the referrals when we start. We're not going to be overwhelming, throwing a load of patients at you because we've been made fully aware that we can't do that. So we're selecting patients that are appropriate for referral to you, but would absolutely appreciate feedback on that. You know, this is new to us as well. And I know you capture a lot of the patient feedback and audit that kind of the successes. So, and we'd be really interested in that data once we start and get a bit of referral pathway established. So any questions, anything come to mind from any of the team?
I don't know, from mine it was just about, like, I think you just answered it then, just about some prescription notes when they first come in, just so we've got a little bit of background information about the client that we're receiving. Sometimes we don't get much from the other way we've sourced referrals, but just basically some limits on exercise would be handy, just so we're not trying to push something they're not able to do. I know they'll probably be aware of that, but sometimes they don't always give us the full picture straight away. But no, I think there'll be things that crop up along the way, really. But yeah, no, that was great this morning. Thank you.
So everybody you've met so far today will be the key points of contact, with your specialist nurses being your main points of contact. So Vicky's obviously fully aware of all the patients that are listed, and Lorna follows the patients throughout their lifetime once they hit adult pathways of care. So they'll be your point of contact. I've sent you all those email addresses, so
yeah,
you've got access to those people. And obviously our brilliant consultant team are just happy to get involved and answer any questions as well. So we can get any questions answered through them as well. We can't envisage any sort of issues with that, but just please feed back to us, and if we're doing something wrong or you're not getting enough information, we can adapt that and make sure that you get the absolute right information about the patient to get the best outcomes for them. So please feel free and to be really honest with us, and we'll get this right as we progress.
Yes, no, I'm sure we will.
Great.
Well, yeah, that's absolutely fine, really,
Great.
from our end.
Lovely. So we will, Thomas, I can share the whole presentation recording with you and your team once I get it downloaded. Anything you can think of, just email, and I will let Angela Telford and the team know that we've done the education and we're ready to start referrals if everybody's in agreement.
Yeah, that's
Great.
fine. Would you be able to send it to me as well, please, Kate?
Yes,
Because we've
of course.
got Ellie, one of our practitioners. She's on annual leave, so she can't make it today.
Yeah, of course. I'll send it to both of you. You can share it. And yeah, I think that's it. Anything else you want to add from any of the team, either side? No? All happy?
No? Yeah.
Yeah. Great. Thank you
Right.
so much for your
Thank you very
time
much.
this morning. Enjoy your lunch and thanks everybody.
No, thanks for your time,
Bye.
everyone.
Thanks
Thank
so
you.
much.
Thanks so
Bye-bye.
Bye. Bye.